Okay, thank you, Nicholas, for the introduction, and special thanks to Peter for that excellent talk, which I can now use and build on that one to explain how all the specific features of the PASCAL system are particularly handy when treating tricuspid regurgitation. And of course, we talk here about mainly functional tricuspid regurg. Now, when it comes to treating tricuspid regurg, there are a couple of anatomical specifics which need consideration. First, in contrast to the mitral valve, we have more and more dense chordae at the subvalvular apparatus. Secondly, you've heard before that the mitral valve is a vulnerable structure, which applies even more so for the tricuspid valve. These leaflets, they're very thin, they're almost see-through, and it doesn't take a lot of force to cause any harm to these leaflets. And then secondly, when we look at tricuspid regurg, we are normally faced with larger coaptation gaps, which need to be bridged. Now, if you remember what's been said about the specific features of the PASCAL device, first, it is a passive closing mechanism, which should be atraumatic, less vulnerable to the leaflets, which is very good for the tricuspid valve. You've seen that the system can be elongated. In an elongated fashion, it has a very low profile, which helps you to escape out of cords once you got it trapped into it. And then thirdly, the opportunity to have independent grasping also helps specifically when you have to bridge larger gaps. Now, in the following, I like to demonstrate a couple of examples of our tricuspid cases and how we try to make the most out of the specific features of the PASCAL device. There are two systems, and I'd like to start off with an example where we use the larger device, the PASCAL device. PASCAL device, and you've seen that, has broad conduit paddles, which allows you to get in a lot of leaflet tissue. And that can be particularly helpful when you are faced with an anatomy like this one with torrential TR, so tricuspid regurg grade 5. We now change from a 1 to 3 grading scheme to a 1 up to 5 grading scheme to account for the almost indefinite values of vena contracta you can see in these patients. So by implanting two PASCAL devices with these wide contoured paddles, we were able to grasp a lot of leaflet and thereby reduce the tricuspid regurg from grade 5 to 1, as seen in that example. Now, the other aspect, which is particularly important for the tricuspid valve, is the fact that we have a passive closing mechanism and a device which can open and close throughout the cardiac cycle. So this video is supposed to run, but it doesn't run right now. But you can see on the video on the left-hand side that it opens up during diastole, during filling, which allows you a larger opening area, but it closes in systole, where it is important to be for the valve to be competent. And now you can also appreciate that on echo after an implant into the tricuspid valve, and you can see that this device opens and closes throughout the cardiac cycle slightly. Two advantages: first, larger orifice area during filling; secondly, less traumatic or less vulnerable to the leaflets. It reduces the stress on the leaflets. The other aspect, and you've seen that in the previous talk, the retention elements, they are located in a horizontal fashion at the distal end of the device, which means that the device normally grasps the leaflet more towards the central part of the leaflet. And we know from his histology work that here the leaflet is more solid, and that means that you can have multiple grasping attempts without causing any damage to the leaflets. Now, like to show you an example. That was a patient where we implanted already a PASCAL Ace device, and this is the implant of the second device to reduce TR further. We did a first grasping attempt with the septal leaflet and anterior leaflet in the device. On the left, you can now appreciate while closing the device whether there is tension building up on the leaflets. That's normally a good sign, indicating that a lot of leaflet is in. We weren't happy here. The anterior leaflet was still floppy and still a lot of color. So we reopened the device and tried to get a larger bite of leaflet into the device. And here we you can see the second grasping attempt, but this also works for the third or the fourth. In general, these grasping attempts, they're very soft to the leaflets and do not cause any injury. And now you can see that with the second grasp, we have nice tension on the leaflets building up, indicating that there is a sufficient leaflet in the device, and that's also then supported by a very only mild residual TR. Independent grasping, obviously very important, especially when you have to bridge larger gaps. You can see on the right-hand side that this was a patient with a lot of tethering, severe annual dilatation, and a gap which was about 10 millimeters. So in that case, we got the anterior leaflet in first, and now we did what was referred to before, the Tarzan maneuver. We tried to swing over to the septal leaflet. You can see here that we were successful to do so. The septal leaflet is now also in the device. You see the leaflet touching the apex of the device. So one leaflet in first, then swing over to the other, and then finally closing the device and releasing it with two leaflets being nicely in. The PASCAL Ace system is obviously the smaller device, and this can be important to use the device, and I can say that already. For me, that's the device by far the standard device now for the tricuspid valve, especially because we quite often are faced with a lot of cords, and therefore it is easier to maneuver in that area with a smaller device. And here you can see an example of a patient with tethering of the septal leaflet, with the septal leaflet is rolling, and here it can be sometimes difficult to get across these cords, but with a smaller device, the PASCAL Ace, here we were able to do so. Again, leaflet in, we came across the cords and then closed the device with a good result. We have some increasing body of evidence that procedure works nicely, that it can reduce TR, reduce it to moderate or less in 86% in that compassionate use series of patients treated in US, Canada, and also Europe. These are early results at 1 year, but we also have now 1 year data. As you can see here, even after 1 year, the percentage of patients with moderate or less TR 86%, and despite the fact that there was a high-risk cohort, we have a low rate of death or death and heart failure rehospitalization. As seen in most trials, as long as you succeed in reducing TR, you will also see clinical benefit, dramatic improvement in symptoms with a reduction in NYHA class, and also a significant improvement at 1 year, but also at 12 months, looking at 1 month and 12 months, looking at 6-minute walking test with a significant increase in walking distance. And now finally, this is our experience treating tricuspid regurg using the PASCAL system. I think there are two messages here. First, both the PASCAL and the PASCAL Ace system, they work very nicely, they're safe and they're effective to reduce TR. And as you can see here, the split at our center, we started with PASCAL and now we treat most patients with the PASCAL Ace device because, as I said, the smaller device is better and easier to steer in a quite crowded and busy subvalvular apparatus, as most often seen in tricuspid regurg. So in conclusion, the PASCAL repair system is a novel system which allows a differentiated therapy for patients with TR. We have the first in-human experience with very encouraging results with regards to reduction in TR, with also now longer follow-up data up to 1 year. And what is encouraging, that the commercial results are very similar and reproduce what's been seen in the studies before. Thank you.
Okay, Philip, as always, a very good and compelling presentation that also makes the case for the use of PASCAL technology in tricuspid and functional tricuspid repair. But still, I am intrigued by PASCAL and PASCAL Ace, and you already mentioned, or you suggested, that you are using these days more PASCAL Ace than PASCAL because of potentially more subtle maneuvers within the valve. But what would be your percentage? How many times would you refer to a PASCAL, and how many times would you opt for a PASCAL Ace in your practice?
So in the vast majority these days, we would use a PASCAL Ace. And this is due to the fact that it's easier to maneuver in a tricuspid valve. Sometimes you have small septal leaflet with a limited landing zone for the device, and with the PASCAL Ace you can get around the fact that you have a limited landing zone. Sometimes you need to implant 2 devices to connect the anterior and septal leaflet, but also the posterior and septal leaflet. In these instances, it's normally better to have 2 smaller devices rather than only 1 larger device. So I'd say that only if you have really very large leaflets and torrential TR, we probably would then still consider to use the PASCAL device. In all other cases, it would be PASCAL Ace. But this is slightly different as compared to mitral.
Also, yeah, so that was my question then for Peter. So how would that translate in the mitral space? Would you also prefer PASCAL Ace, or is there more room for a PASCAL, the conventional PASCAL?
I think there is no clear-cut answer to this, and I think the colleagues from Mainz will answer this differently, because we tend to use the PASCAL 10 still as a first choice device, because in most of the cases it's not too big. We prefer the PASCAL Ace in very small valve areas, and I would say that the percentage is still above 80% PASCAL 10 compared to PASCAL Ace on the mitral side. On the tricuspid side, I completely agree with Philip. We have a tendency that it goes to 100% PASCAL Ace. But I think Ralf has a deeper insight into using PASCAL Ace in the mitral side.